Thank you very much, Dr. Hirsch. Our next talk is also from McGill University, Dr. Gab Abikhzer. Dr. Abikhzer completed nuclear medicine training here in McGill. He pursued a 2-year clinical and research fellowship in 2011 to 13 at Rambam Healthcare Services in Haifa, Israel, focusing on PET-CT and advanced SPECT CT using new cameras and tracers. He's currently assistant professor at McGill University and recently has been promoted to chief of the nuclear medicine section at the Jewish General Hospital. Dr. Abikhzer has published over 40 articles, especially with interest in SPECT, FDG PET-CT for infection and inflammation. He's currently involved in the Society of Nuclear Medicine as well, and is treasurer and upcoming president of the General Clinical Nuclear Medicine Council. So Dr. Abikhzer, he will be speaking about lung scintigraphy and chronic PE and CTEPH.
Thank you very much. Okay, so I work closely with Dr. Hirsch, who is the top referrer, and we'll be talking more about the VQ aspects of chronic thromboembolic disease and chronic PE. So pulmonary hypertension is defined as high pulmonary pressures, as he explained, and there's many different reasons for pulmonary hypertension. We're going to focus on group 4, which is chronic thromboembolic disease, which is where the VQ scan plays a major role in the diagnosis. So it occurs after about 0.5 to 4% of acute PE events. Many patients don't even have a history of PE when they are diagnosed with CTEPH, and there's a much higher risk in patients who've had recurrent PE to develop CTEPH. I'll skip the clinical presentation. So the VQ scan shows, quite a evident pattern of, planar high probability, or on SPECT, multiple perfusion defects. It's really, usually a straightforward VQ image of large clot burden. So what's important to know is that there is pulmonary hypertension that can sometimes cause abnormalities on PE, but are not related to CTEPH. And not only that, but patients with pulmonary hypertension can develop in situ thrombosis of their pulmonary arteries as a complication of their high pressures, but they're not CTEPH as well. So on lung scintigraphy, the difference is, as he showed, it's more a mottled appearance and distal disease rather than segmental and subsegmental defects. So here's an example of more heterogeneous activity, mottled appearance on a SPECT scan. So what's important is to differentiate between abnormalities caused by pulmonary hypertension, the disease itself, and those caused by chronic thromboembolic disease, which resemble more really segmental defects and not peripheral heterogeneous perfusion. So PE in the acute phase is characterized by a large central thrombosis that could include the vessel, and then with time it could reorganize as bands, as webs, and then eventually it could go more towards the lumen and develop more chronic disease, and that's why Dr. Hirsch was explaining that the CT can sometimes not see these chronic PE defects. Normally, PE is expected to resolve with no or minimal residual hemodynamic consequences, and that should usually occur within 30 days. A VQ scan should resolve by 3 months, and I trained at McGill. Unfortunately, I didn't have the chance to work with Dr. Rosenthall, but in the teachings that were transmitted from him, and there were multiple of them, one of them is that when he used to go to conferences, he used to show a scan and say, is this acute or chronic PE? And then people would say, oh, it's acute. And then he would show a scan from 3 months ago and show it was the same thing. So no, it's chronic PE. The point was that you can't really tell if it's acute or chronic PE from the scan, because you need interim scan. And that's why it's important to get a baseline scan after 3 months, because when you're going to do follow-ups and they are a chance to have recurrent PE, then if they come again, you're not going to be sure whether it's acute or chronic. So here's an example of a study done initially in April showing multiple perfusion defects consistent with PE, and in the follow-up in August, it was normal. So this is resolved PE. This is what most of the patients will look like. Now, in this example, there was PE on the initial study in September 2019, and on the follow-up study, there is improvement, but there are still some residual diseases that persist, and therefore there's some chronic PE. And it's important to establish this baseline because on any follow-up, if you see the same defect, then it's not going to be a new PE, it's just going to be chronic PE, and the treatment will probably be different. So in the workup of imaging for patients with CTEPH, chest X-ray is usually obtained, an echocardiogram, and a right heart catheterization. So in order to rule out CTEPH, and I think this is the practice of Dr. Hirsch, is that most patients with unexplained pulmonary hypertension will receive a VQ scan as a screening for CTEPH. Then we do the VQ scan. Why? Because it's a very good first-line test with a very high negative predictive value. If the VQ scan is negative, then you've essentially ruled out CTEPH as the cause of the pulmonary hypertension. CT angiography can miss the disease in certain subsets of the patients, and there's different findings that they can see. It's more reorganized clot and mosaic attenuation pattern of the lungs. So when we look at the performance of VQ SPECT and CTA, we can see that the sensitivity of VQ SPECT and specificity is very high, with an extremely high negative predictive value, whereas CT, the sensitivity varies widely between the studies, but is less than that of VQ, planar or SPECT, but it still has a very high specificity. Then the diagnosis is confirmed with pulmonary angiography. So how do we interpret these studies with chronic PE? And so in general, in patients with CTEPH, compared with acute PE, the defects are going to be more diffuse and multi-segmental. And they're going to involve a large number of segments. So if you see 1 or 2, 3 segments, and we'll say 1 or 2 segments with some equivocal defects, it's probably not the cause of the chronic thromboembolic. It's probably not the cause of the pulmonary hypertension. And we're more strict to call it CTEPH than acute PE because it has to be a large clot burden in order to cause the disease. So we'll pass a lot of these little peripheral defects, a lot of these equivocal defects, as they are not likely to cause the disease that we're looking for, the CTEPH. So therefore, some have proposed criteria that it should involve at least 50% of a segment to be considered thromboembolic. And we have to differentiate between CTEPH and the small segmental, non-segmental defects that can be seen in idiopathic pulmonary hypertension. It's recommended to inject a lower number of MAA particles than in regular patients. And the findings that we see is going to be mismatched defects that can be occluding thrombi, they can be related to chronic remodeling of the pulmonary vessels, and those are the ones that tend to be negative on CT and angiography, the more distal chronic remodeling defects. And there could even be some matched defects, which are not typically caused, but they can theoretically be related to lung infarcts, but can also be related to compensatory reduction in ventilation, secondary to chronic hypoperfusion. It's possible that you can have normal perfusion despite having a CT that shows a large central clot, and that can be related to recanalization or collateral circulation. So in this example, we can see that there's multiple defects. This is a large clot burden, and it confirms the diagnosis of CTEPH in this patient with pulmonary hypertension. False positives could occur, but it really depends on the interpretation criteria. Really, VQ scans with low clot burden should be interpreted with a lot of caution, as they are not likely to cause the pulmonary hypertension. So in this case, how would we conclude our impression of the study? Would we say PE is present? Would we say no evidence of CTEPH? Or would we say, okay, there's chronic thromboembolic disease, but it's unlikely to cause CTEPH? So here's an example where the perfusion is a bit heterogeneous. Here we have another example where we see that we see on the SPECT of this patient that the perfusion is heterogeneous, but there's no typical defects, just a bit of heterogeneity. This is something what we would say, we're not sure, but would we say small subtle perfusion defects, and we question ourselves, is this enough to cause CTEPH? And we'll often have this discussion amongst our colleagues at the hospital, and we're going to say, no, this is not enough, doesn't look. It's a gestalt, you use a lot of gestalt diagnosis to call a CTEPH. So here we'd probably say, yeah, okay, there's some abnormalities, but it's not enough to cause CTEPH. We wouldn't call it CTEPH. So false positives, remember these patients can have multiple other reasons for chronic, for pulmonary hypertensions, many amongst which can cause abnormalities on VQ scan, such as fibrosing mediastinus, sarcoidosis. Many interstitial lung diseases cause classically a lot of defects. And that's why it's very important to look not only at our VQ scan, but also look at the CT that's often done, or if you do a VQ spec CT, if there's any abnormalities that can explain your perfusion defects, sometimes, but not always associated with ventilation defects, because many of the other causes of pulmonary hypertension could cause false positives, but taking everything together, looking at the lungs, looking at the CT, looking at the patient history is going to help us rule out and eliminate these cases as false positive. And instead of saying it looks like CTEPH, a classic would be interstitial lung disease. We would see severe interstitial lung disease on the CT, and we would just explain our defects based on that, and we wouldn't call it CTEPH. But an abnormal perfusion, it would be sometimes it's even worse than the ventilation, but we should not call that as a CTEPH pattern. False negatives can occur, and they can be due to non-occluding thrombus. We're not sure exactly what's its role in leading to pulmonary hypertension in such a case. It can be distal disease, which is after the subsegmental level, could play a role in leading to pulmonary hypertension, and in patients after surgery, it could be responsible for the persistence of pulmonary hypertension in about 10% of the patients. But once you start having distal disease, it becomes hard to treat, either with surgery or with angioplasty. But it depends how distal it is. The angioplasty could help in more central disease. Now, other false negatives is when the chronic thrombi reorganizes and there's collateral circulation, and there remains an abnormal VQ pattern, and that can be a false negative. But usually, this type is going to be positive on CT because they're going to see some clots, even though your VQ is not going to be positive. So it's important to know that after treatment, there's going to be we have to be aware that there's post-treatment changes that can occur. The first one is hyperperfusion, and that's in the immediate post-operative period that and should tend to resolve after lung. And what happens is that normal lung may be photopenic relative to reperfused segments. And for example, in this example, where the large defect inferiorly after the surgery improves, but with time, and then it's even more intense than usual, but with time it becomes more homogeneous with the remainder of the lung. So that's hyperperfusion that can occur after treatment. Then you have the vascular steal phenomenon, and that's related to relief from high vascular resistance by removing the clot, and therefore causes some sort of steal of blood flow from the segments unaffected by the blood clot. And these segments are usually going to have high pulmonary resistance from chronic remodeling, and they could present as new defects after endarterectomy. And if the patient doesn't have symptoms, then usually that's attributed to that. So it's something to be aware of, as on this example, where there's some new abnormalities that are present, but that tend to resolve after time. So it's important to realize that it's not exactly the same disease. We don't interpret the same way, acute and chronic PE, and especially CTEPH. It's different patient populations, and it's different endpoints. Here we're looking for patients that we can help treat with surgery, with angioplasty, and so we have to identify on VQ scan the patients who have this high clot burden that can benefit from it, not the small ones, not the patients who have a couple of distal defects that are non-specific. You really want to choose the patients. Oh yeah, from the back of the room, you can say, oh yeah, this is a high probability PE study back in the planar days. And because we're much better at this, not our sensitivity is going to, I mean, you don't need a SPECT to diagnose this, but, whereas there's a large difference between planar and VQ and SPECT in the acute setting, in the chronic setting, it's much less important because we're looking for large defects. So VQ SPECT, when in comparative studies, does have higher sensitivity and similar specificity with VQ planar imaging. And SPECT can detect a lower burden of VQ abnormalities, but we should still be careful because if it's something that you only see on SPECT, it's probably not the cause of the pulmonary hypertension. And when you do have a SPECT, it's another advantage of doing a SPECT is that you can identify much better the territories, the vessels, which you can guide the surgeon or the angiographer to go towards rather than on the planar, which is much more difficult to exactly localize the defects and the territories that are involved. And you can even use some software registration to fuse it with the CT angiography and then really give them a good guide of where they want to go, where their best results are going to be from targeted treatment. You can even, some people even have proposed doing a perfusion-only SPECT, which could also be good. It'll give similar sensitivity and specificity. The advantage is that it's a quicker test, and it could be good in unstable patients. But the disadvantage is that there's many other causes of pulmonary hypertension that give also lung disease, and that you're going to cause you potentially could cause more false positive. Classically, interstitial lung disease is a frequent cause of pulmonary hypertension, and without the ventilation, it may be difficult to identify unless you do maybe a VQ SPECT CT in such a case. So here's an example where even on the pseudo-planar images generated from the SPECT, it's quite obvious. And this is what it should be. It should be a really evident diagnosis even on planar images. And here's a SPECT where you can localize the defects much more accurately than on planar images. So what are the diagnostic thresholds? That has been looked into. And in the back in the past, there was one large perfusion defect, but they did a nice study where they looked at looked at patients with the CTEPH and looked at what the minimum criteria on VQ planar images is, and they determined that the best results is going to be obtained with using 2.5 segmental mismatches as a minimum criteria to cause that the VQ scan chronic thromboembolic disease or whatever pattern you see is diagnostic of CTEPH. So on planar images, and we don't really know what the data is on VQ SPECT, but it should be similar, is that you need at least 2.5 segments in order to call that CTEPH. So, one segment, 1.5 segments, 2 segments. In this study, that was not enough to be the cause of CTEPH. So that's important to know. You want a good number of segments involved. So what's important is, according to the CANM guidelines and the ENM guidelines, there is an indication to do a follow-up VQ scan at 3 to 6 months in all patients who present with PE. There's benefits to that because it'll obtain a new baseline study if there's a recurrence of symptoms. Also, by doing the follow-up study at 3 months, you can see what the final reperfusion status is. You should expect that the defects resolve after 3 months. We're not sure exactly what the prognostic value is, but it is important to know what or to tell. There may be eventually some anticoagulation therapy that can be tailored based on the results of the VQ SPECT in patients who have persistent typical defects secondary to chronic thromboembolic disease. In Canada and the rest of the world, we're all doing SPECT. The only outlier is the USA, but hopefully they'll catch up now that they have approval of Technegas. Quantitative studies are something that could help a lot in this segment because using artificial intelligence, using quantitative measures with perfusion index that can look at the total clot burden, that can be used to develop a minimum criteria for patients to be diagnosed with CTEPH, and also they could be used in the follow-up after surgery or angioplasty to look to see if there's any improvement in that index, which could correlate with improvement in symptoms. So in conclusion, follow-up VQ scan is indicated at 3 to 6 months in all PEs according to the CANM and ENM guidelines. It establishes a new baseline, which will allow us to differentiate between acute or chronic PE should the patient ever need to have a VQ scan in the future. It could have some prognostic value as well. VQ scan is very important in the workup of patients with CTEPH to identify it as a cause of the pulmonary hypertension, and should be routinely obtained in patients with unexplained pulmonary hypertension. Using VQ scan planar criteria, which is the only ones that have been obtained so far, the optimal diagnostic criteria is 2.5 segmental mismatches. We don't have exactly the data yet on SPECT, but that will be hopefully coming in the future, as well as quantification will likely allow us to better diagnose and follow up these patients.